TopMedTalk.
This is TopMedTalk, the broadcasting arm of EBPOM, Evidence Based Perioperative Medicine. The EBPOM World Congress is taking place this year between the 7th and the 9th of July at the British Library in London. Check out ebpom.org now.
So this is the Siobhan Mythen Plenary Lecture. Quite a few of you in the room, I think, knew her very well. Quite a few of you in the room knew her. Dingle was Monty's conception, but Monty, Siobhan and I have worked on Dingle since the very beginning, and she was the heart and soul of the Dingle meeting. She'd have been absolutely delighted to see John, who she was very fond of, give this lecture today. Now, I'm not going to introduce John, slightly unusually, because as it turned out when we were talking to the contributors for the meeting, we had two presentations that just fit together really neatly. So I'm going to ask Professor Ellen O'Sullivan to give her presentation. I'll introduce Ellen, and then Ellen's going to kindly introduce John. And I hope you enjoy the next hour or so, and I hope you also have a chance, those of you who knew Siobhan, just to reflect and remember what a lovely person she was. She'd also been delighted to know that Ellen was involved. So Ellen got a long CV. I'm not going to do the whole CV, but she's, amongst other things, a previous president of the college here in Ireland, previous president of the Difficult Airway Society. She's one of the founders of WHAM, and. So extremely experienced and valuable leader in our specialty. So Ellen, thank you very much for kicking this off, and thank you for introducing John.
I'm delighted to be the act before John and also to be on the stage for the Siobhan Mythen Lecture. She was so fantastic, as you said, the heart and soul of the meeting. Now, just a little bit about where I work briefly, because it's relevant. I work in St. James's Hospital in Dublin, which is a large teaching hospital attached to Trinity College Dublin, and it has a big cancer workload, which suits me with my airway interests. So we do a lot of head and neck cancers. We're a national maxillofacial unit. We have the National Adult Burns Unit. And for 14 years, I've been the director of the Fellowship in Airway Management and Advanced Simulation. Now, we deal with a lot of difficult airways, all sorts of lesions, benign, malignant, stenotic lesions, and so forth. And I'm not going to tell you how we do those. What I'm going to kind of just dwell on for this short presentation is the impossible anatomical airway and trying to avoid this. On far more of means dead man or dead person. And you probably wouldn't see it today, but if you're in Slayhead, you might see the northern Blasket Island in the sunset. It's lovely, but maybe not today, as I say, and it looks like a dead man. That's the direct translation from the name on Far Morov. So in this lecture, I'm just going to outline what we mean by the impossible airway, a little bit about the history of it, what evidence have we and how to best manage it, a little bit about priming and teaching and training. So the impossible airway was defined by Andy Hurd recently, actually from Perth in Australia, who had a particular interest in this little bit of the neck. He defined it as the inability to intubate with the human and technical resources available prior to the onset of critical hypoxemia. And in fact, more correctly, I think, is the inability to oxygenate. And so we call it the can't intubate, can't oxygenate scenario. Now, everybody recognises this picture of Elizabeth Taylor. This is her doing the filming of the film Cleopatra with her outfit on. Notice she's a vertical tracheostomy scar. And in fact, I didn't know this relatively recently. While she was filming it, she got ill and was transferred back to London. I don't know which hospital in London. And she had severe pneumonia and needed a tracheostomy, apparently. But while she was recovering in the Ritz Hotel, I think in London, she heard she was nominated for an Oscar. So she flew back to LA to receive her Oscar. And there she's in her fur coat and her Hermes scarf being kind of brought onto the flight to go to receive the Oscar, which she won for this film, Butterfield 8. And interestingly, that was the last black and white movie to get an Oscar. But Shirley MacLaine was also up for an Oscar, as was the film The Apartment, which was a very good film with Jack Lemmon and Shirley MacLaine, as I say. She was furious and she apparently quipped and said, "I lost my Oscar to a tracheostomy." So I think tracheostomies have had a bad influence on her getting her Oscar. Another link with, I suppose, the filming of Cleopatra in Egypt is that the early descriptions of tracheostomy date back to 3000 BC in Egypt. Another interesting fact, I think, about this man, and you probably know it, the Americans will know it, the first American president died in 1799 in his 60s from bacterial epiglottitis. And there's a very good paper in the New England Journal on this called The Death of a President, and it really is worth reading. He was a fit man, had been out in his estate on his horse like days before. He got gradually more ill and couldn't swallow, was having difficulty breathing and so forth. 3 physicians were called. They all argued about what they should do, nothing new. They did enemas, they phlebotomized him many times. He lost about 3.5 litres of blood, which they were criticised for later. But they did call a consultant or a doctor who had done 50 tracheostomies. He came from Philadelphia, but they shouted him down. He wanted to do a tracheostomy, saying it would be absurdly futile. Might have been futile, but at least it would have been the right thing to do. And there's always been this fear of performing a front of neck. I think we call it EBPOM, emergency front of neck, and the consequences thereof. So what do we say in our guidelines when we come to that part of the guideline where we can't intubate and can't ventilate? There are 2 big guidelines out there that are mainly used, the DAS, Difficult Airway Society Guidelines, which were published in the British Journal of Anaesthesia in 2015. They were launched at the WAM meeting, which was held in Dublin as well that year. And Craig Lyons and myself looked to celebrate the 100 years, I think, of the BEJ. We looked at all the airway papers that were published in the journal over 100 years. And the most cited in those 100 years were, in fact, the DAS guidelines. And why was that, do we think? I mean, it was because I think for the first time there was a step-by-step approach for this unanticipated problem, a difficult airway. The flow charts are easy to follow. There was standardised teaching suggested in standardised equipment. And when you came to this point where you tried your intubation 3 times with different equipment, you had tried to rescue with a supraglottic, you failed, you're in your last attempt at face mask ventilation, kind of patient desatting, drama maybe arresting at this point, you're in the can't intubate, can't oxygenate scenario, EBPOM. The guidelines say you declare it, you call for help, and you move to emergency front of neck access, and you do a scalpel cryostomy. Now, that is one decision you have to make, just one, and that's why I think they were popular. The guidelines say you use a bougie size 10 scalpel and a size 6 tube. Again, didactic, 1 step, 1 decision. In contrast, the 2022 latest ASA guidelines, which are very much, I suppose, more evidence-based in that sense, and this time they had, some of us were added to it for Europeans' perspective, and it's quite similar down to that point where you have 3 attempts at face mask, intubating and supraglottic, but then you're in the can't intubate, can't oxygenate, and they give you these choices. You could do a surgical cryostomy, or you might do a needle, or you might use a large bore, or you might use a rigid bronch, or put them on ECMO. So these were all the alternatives given in that scenario. So basically, quite confusing and quite a lot of decision making, particularly in this scenario where you're failing to intubate. You have to make a decision. You have to get the team around you, and you all have to be on the same page at this point. You can't be deciding which or whether. In the Australia guidelines, they go for cannula, and then if that fails, move on to the surgical approach. So very didactic and a very simple position that the patient decide. The only decision there is whether you can palpate the cricothyroid membrane or not. If you can't, and most likely you can't, you do a vertical incision, 8 to 10 centimetres, like this sort of patient where you can't palpate your cricothyroid membrane. And that distance was considered very long. But one of our great researchers in this area is Conal McCall from the Mater in Dublin, and he's validated that length of incision to make sure you don't miss your cricothyroid membrane. So this became, in fact, people at the DAS meeting, at the WAM meeting in Dublin, walked out of the room, particularly, some Australian colleagues, because they were so annoyed that we didn't continue to suggest a needle cricothyroidotomy. So we then set up an app to look at these cases. There isn't much evidence out there, but again, app helped us to get some evidence that the bougie cricothyroidotomy is more successful when performed, particularly versus the wire cricothyroidotomy technique. So the guidelines also said we should be trained in it and repeated at regular intervals, and it should be done timely fashion. I'm sure by the time George Washington would have got it, would have been too late, and probably the poor surgeon would have been up for murder or manslaughter. The closed claims also showed that delayed surgical airway was a major problem in 40% of those cases that went to claiming. Priming is the other new thing we talk about, making sure that you get from the upper airway to move quickly from the upper airway down to the ephona if needed. So declaring it and performing it in a timely fashion. Making sure you've allocated someone, you have pre-packaged, the plan D is there and ready to go. You paralyze the patient and you've done the assessment. So after you've failed to intubate, you get the kit. After you've failed to put a supraglottic in, open it and then do it. So we call this a halo technique procedure. It's a high acuity, low opportunity procedure. So you must prime, you must have your equipment there, and training should be standardized and repeated at regular intervals. We have some evidence now that from Denmark, some good work, that ephona training should be done every 3 months. We actually do it every 6 months. So, and there's ways of doing it. We use 3D printed models in our department. We use high fidelity for the scenarios, but 3D printers for just doing the technical bits. We're doing AI again, and we're doing VR for training in ephona with UPenn. We've got a good bit of funding for that now, and we have the software and about to trial it. So, and these are the sort of things we're looking at doing. So we should all be ready for CICO and for the scenario like the George Washington scenario. And we still see adult epiglottitis coming into our departments. We should be prepared personally. The institution should be prepared, and we should develop a fearless phona mindset. Now, that was a brief run at the impossible airway, the anatomically difficult airway. NAP4 highlighted the fact that there's also the physiologically difficult airway, as is important, and the logistically difficult airway. So we'll now hand over to the next speaker. There are guidelines on that, which DAS produced in 2017, which became very useful when COVID hit. But the person who is most qualified to speak on that is the Siobhan Mythen Lecture today. And we're very lucky to have John to speak on this. John is Professor of Anaesthesia and Intensive Care at Galway School of Medicine, University of Galway, Director of Clinical Research at the National University of Ireland in Galway. He's Co-Director of Clinical Illness Research at St. Michael's, Toronto, where he spent 7 years, some of it in administrative and doing research there. His research focuses ARDS and sepsis pathophysiology. He's huge interest in cell therapies and gene therapy, always been interested in hypercarbic acidosis, and he engages in large global studies, many of which you will have heard of. So we're very proud that John is going to give the Siobhan Mythen Lecture now. Thank you very much.
I'm absolutely delighted to be giving the Siobhan Mythen Lecture. We used to come here quite a lot in the noughties with our family. Siobhan was always just incredibly helpful to us. It used to make us really feel welcome, and I'm deeply honoured to be given this talk. I don't have any conflicts of interest of relevance. My funded work is all in regard to cell-based therapies and gene therapies for acute respiratory distress syndrome. So I kind of got involved in this sort of by accident, and I'll tell the story a little bit as we go along. My background, I'm an anesthesiologist, and I do most of my clinical work in the ICU. But, in the ICU, this is one of our highest risk procedures, is airway management and urgent intubation. It tends to occur at difficult hours. A lot of it happens at nighttime. Patients are unstable, they don't have a lot of a physiologic reserve, and the stakes are higher. If we lose control here, the likelihood of sort of long-term adverse effects are higher. And as I said already, a lot of these happen out of hours, junior staff and so forth. And the consequences are potentially more severe. In terms of how we know about this is an old study, but it's really a key study. It was the NAP4, I think it was, but the National Audit of Airway Outcomes in the UK. And they looked at serious adverse events in the operating rooms and theatres, in the emergency room and in the ICU. And they were looking at death, brain damage, unexpected ICU stay, and need for emergency airway access. So what they reported, the key paper was in 2011, as you'd kind of expect, most adverse events were in the theatres because that's where most airway management occurs. So about 2/3, with just 10% in the emergency department and just under a quarter in the ICU. I would say kind of as we expected. But interestingly, when you looked at the outcomes, the risk of death or brain damage was significant in the operating theatres and in the ED, but they were actually a lot higher in the intensive care unit. And so that really started to get people in the ICU thinking, right, well, okay, some of this is about our patients and how sick they are. 42% dying, like that's just an extraordinary number, right? And basically 61% of airway complications in ICU patients led to death or brain damage. That's really quite a quite a shocking statistic and got people thinking. So over time, we are very focused from an anesthesia background on the anatomic airway, and rightly so, right? This sort of classic disaster of the fit young patient coming in for a relatively minor procedure who ends up with brain damage or death is all of our nightmare scenario, right? And, as Ellen has shown very, very well, and, the DAS and other organizations have done a superb job in really getting us up to the level needed to manage these patients. I mean, we had an emergency front and neck access in our own hospital just a month ago. A surgical registrar and anesthesia registrar had both been on the same course, and it was the surgical registrar declared a CICO, and they got a front and neck access and saved the patient. And that's fantastic. I don't know if I was at that person's stage, would I have managed that? I don't think I would. But now we talk as well, we make this distinction, right, between the physiologic and the anatomic airway. And one of the things I sort of want to tease through as I go through the talk is that maybe some of our background as anesthesiologists has leaked into how we practice in the critically ill airway management situation, and that we may need to rethink some of this. So the physiologically difficult airway is basically the very sick patient with low reserve who may suffer very severe consequences as a result of the procedure required to intubate them. And you may be really unlucky, of course, and get both in the same patient. So as I said, I got into this a little bit by accident. I had worked quite a bit with Giacomo Bellani before we got together, and we published this paper in JAMA in regard to outcomes. It was an observational study. We had a large participation in Asia, particularly India, North America, Australia and Europe. We enrolled just under 3,000 patients, or we had a full data set, I should say, on just under 3,000 patients. There was more than 3,000 enrolled. So these were all patients critically ill in the emergency department or the ICU and needing emergency airway management. And in terms of this, the age is about which is expected, early 60s, about a third women, which is again fits with the ICU demographic. A couple of interesting things. One is, the reasons for intubation. The two big ones were, as you expect, respiratory and neurologic impairment, right? So the dominant one being respiratory failure, but a big chunk of coma as well. When we looked at adverse events, the dominant one by far was cardiovascular instability. So that was severe hypotension, need for pressors, new need for pressors, or need for fluid boluses. And that was over 40%. When we looked at difficult intubation, it was there, but a much lower number, right? So of the order of about 5%. So when we look at the numbers in detail, what you see is that over 40% of all patients having in the ICU or the ED having emergency management had significant cardiovascular instability. About 10%, just under 10% had severe hypoxia. Now that is severe, it's less than 80% oxygen saturations. And about 3% had a cardiac arrest as a result of the intubation procedure. So the dominant by far was hemodynamic instability and cardiac arrest. One of the things that, it didn't surprise us, but it was interesting that it came out was we often think that, what happens peri-intubation, okay, they might be a bit unstable, we'll get them on a bit of a pressor, pop in a line and get them on some noradrenaline, and we can kind of put that to one side. But if you have an unstable peri-intubation event, the severe one, it does translate through to a poor outcome. These patients are more likely to die. That's for all, and it's particularly for cardiovascular instability. So you are at higher risk of dying if you're critically ill and you are unstable around the intubation period. So it seems to us like an area we kind of need to focus on. We would expect, of course, that cardiac arrest would be poor outcome, but interestingly, hypoxia around intubation was less of a long-term risk than hypotension. And again, that's sort of, we're really primed to worry about hypoxia, right? And so, again, just the idea that we need to maybe rethink this a wee bit. What about repeated intubation attempts? I think are very focused on getting the tube in first time. And that's good. I mean, I'm not saying it's not good, but we're very, very focused on it, right? Most of our intubation studies are, how many you got the tube in the first time? That's our primary outcome for a lot of our intubation studies. And yes, you are more likely to have an adverse event if you don't get your tube in the first time than the person who got it in the first time. But it's not dramatic. Interestingly, it's really only the hypoxia. And again, that kind of makes sense, right? But it's showing you already the hypoxia wasn't really clearly linked to the longer term outcomes in these patients. So maybe we're overly focused on getting that tube in right away first time. In terms of the intubation procedure, what we saw was that most patients were bag valve, bag mask ventilation. Again, as you'd expect, nearly 2/3 of the patients. Relatively, this was 2020, so not that long ago. A relatively little high flow, about 5% of patients, of these critically ill patients, had high flow as part of their pre-oxygenation method. And only 17% had video laryngoscopes. And so I want to talk a little bit about that, because they've had a kind of a checkered career in the ICU, the video laryngoscopes. And again, waveform capnography, only a quarter of the patients had waveform capnography. Now, I think that would be surprising to us in the UK and in Ireland. But the reason this is important, of course, is going back to the NAT4 audit, which very clearly highlighted the need for waveform capnography, and that it was implicated, the lack of it was implicated in 3/4 of the deaths in the ICU. So really, that was strong. And again, maybe that speaks to, this audit would have had more of an impact in the UK and Ireland maybe than in other countries. And when we looked across the globe at this, 40% of intubations had capnography in the ICU, under a quarter in the ED, and 6-7% on the wards. So clearly a job of work to be done there. So how do we manage these patients, presenting to us, these critically ill patients, and what do we need to look at? And there's a lot of stuff we don't know, I think, and that's important to say at the outset. In terms of minimizing hypoxia, a lot of work is being done looking at optimal ways to pre-oxygenate these patients. So when we think about this, there are 3 phases of the pre-oxygenation, right? So there's the part where the patient's awake and, in control of their own breathing, that pre-oxygenation phase. Then there's a phase after you've induced anesthesia, but before you've started to manipulate the airway. And then there's a part where you manipulate the airway, right? So that's the apneic phase. And so what works for one may not work for the other. This is a network meta-analysis. So what we're basically looking at is bag mask ventilation or spontaneous ventilation, high flow, non-invasive ventilation, and then combinations of these. So this is a new meta-analysis from the group in Hamilton, Canada. So what they showed was, again, the data is reasonably clear that high flow and non-invasive ventilation both outperform standard face mask. With some evidence, just one study actually is the French study looking where they combine both non-invasive and high flow. And this is one of the interesting things, of course, with high flow is you can combine it with other modalities, and it continues to provide some degree of support while you're manipulating the airway. So, the evidence there's not a huge amount of evidence there, but what is there suggests that combination approaches with either high flow and non-invasive as a combination in these patients may be the best. This is work from Craig Lyons. Craig is a recent appointment to our department in Galway. We're delighted to have him. Craig has done a lot of work looking at apneic oxygenation and pre-oxygenation strategies. This is a study he did in our department where he looked at different pre-oxygenation strategies. Now, this is in the operating room. It's not in critically ill patients. But he compared face mask to high flow to then a combination of high flow with a mouthpiece delivering oxygen. The idea with the mouthpiece is, of course, with high flow, if the patients have their mouth open, a lot of the gas or the oxygen just escapes out. And what he was looking at was apnea times. So what he saw was that the black line here, so this is the time for the oxygen saturations in a pre-oxygenated patient to drop below 92%. So again, these are surgical patients, so the apnea time is long, right? But what he saw was that with high flow, in addition, instead of face mask, he did extend the apnea time, and with the mouthpiece, there was a substantial further extension of apnea time. So again, this is kind of an interesting thing to look at in the critically ill patients. And he looked also then at PaCO2, because there's this work that suggests that high flow can wash out CO2 and actually have a ventilatory role. He didn't see that in this study. But CO2 did rise actually quite slowly. Craig then also looked at different flows. So when we look at high flow, we tend to just stick to 40 or 60 litres. But Craig pushed it out to looking at 70 versus 120. And again, the black line is the control. This is just standard oxygen. And then the 70 litre high flow versus the 120, there was no advantage of 120 compared to 70. So again, we're probably okay to stay within our sort of usual range. This is an amalgam of a number of different studies, but what it's looking to show is the risk of severe hypoxia during pre-oxygenation with high flow. And what it's showing is that it's dependent on the P-TEF ratio of the patient. So the degree of pre-existing oxygen deficit the patient has, that reduces your time. So the data I've shown you has all been in healthy patients. So we have to look at this in the critically ill patients before we can really know whether or not these strategies would work in that patient group. But you can see, if you have a P-TEF ratio of 100, you have a very high likelihood of desaturating during the airway manipulation, even with high flow. And it's sort of talked a little bit already about this, but in terms of the importance of first-time intubation success, As I said, the risk of hypoxia does increase, but from what we could see in intube, that didn't really translate through to a higher risk of death in the patients overall. And I want to focus on the video laryngoscope work. So this is a French trial done in 2017 where they looked at video laryngoscopes in the ICU, so standard direct laryngoscopy versus video laryngoscopy. And what they saw in their study, which is like an adequately powered study, they saw no difference in intubation success, which is interesting. Some studies, early studies, actually showed that the video laryngoscopes were less likely to have intubation success. But they saw no difference between direct and the video laryngoscopes. But what they did see was there were more complications, particularly around hypoxemia in the patients that had the video laryngoscope. So this tended to speak against the use of video laryngoscopes in the critically ill. So we looked at this as part of a sub-study of the InTube study. And as I said already, the bottom box is the important one. So about 500 patients had been intubated with video laryngoscopes compared to about nearly 2,500 with direct laryngoscopy. So predominantly direct laryngoscopy was what was used in this observational cohort from 2020. What's interesting is the geographic spread. So North America and Australia use a lot more video laryngoscopy than we do in Europe. I think this is changing. I think we're using it more now, but certainly even up to a number of years ago, there was a lot more use. So over 50% of all critically ill patients were intubated with video laryngoscope in Australia and New Zealand, almost that in North America, whereas in Europe it was like 13%. What we saw when we did a multivariate analysis controlling for illness severity and so forth, we saw that the opposite to what the French study had seen, actually the video laryngoscope seemed to be associated with more intubation success, and the adverse event rate for cardiovascular instability was higher. So they had more cardiovascular instability when they had video laryngoscopes. The most recent study looking at this is the study from the US, and it's the biggest study done so far. And what they saw was, again, the reasons for intubation were similar to intube, but higher incidence of altered mental status, but the second then was respiratory failure. And some of these patients, the reason proportion of them were considered to be difficult to intubate. So it's the standard criteria for anatomic difficulty. And what they found was a very significant higher rate of first pass intubation with the video laryngoscope. So what's different? So I've shown you 3 studies. One showing that it was worse, one showing that it was kind of a mix, and this one now showing that the video laryngoscopes were more likely to be successful. The important message is that in the US, the people using the video laryngoscopes, that was their default approach. So they were well trained on them. Whereas in the French study, they were predominantly, their default was the direct laryngoscopy. So I think what we find as we are introducing these more into our ICUs, and people get better with them, get quicker with them, they are safe and in some ways maybe better to use in this cohort. So yeah, so you can see, if they use it less than 25% of the time, they were all favored the video laryngoscope, but the more practice they had, the more they use it in their practice, the higher stronger the association with first pass intubation success. So in North America, the dominant use by these. And the other point to make here is the people doing the intubations. They were mainly emergency medicine and internal medicine. There's a very small amount of anesthesia residents doing the intubations here. So some of this depends on your basic familiarity. Of course, anesthesia trainees will be more familiar, generally speaking, with the direct laryngoscopes. What about cardiovascular collapse? So as I said already, the cardiovascular collapse is probably the area we really need to focus most on. This is a study called the prevention trial. They looked at fluid bolus administration. So patients who were critically ill patients who were requiring intubation were randomized to receive 500 mils of fluid bolus versus standard care. And it looked at the incidence of cardiovascular instability. And what they found was no effect of the fluid bolus. So the fluid bolus, it did not improve outcomes in any subgroup that were being intubated, and in fact, if anything, the diamond is the wrong side of the line, and that it favoured the no fluid bolus. So fluid bolus is no longer recommended. This is again a sub-study from the InTube study. So we looked at cardiovascular collapse, and we wanted to try to understand, could we associate any elements of the patient management with the risk of cardiovascular instability. And we looked at a few different things. One thing we looked at was the pre-use of vasopressors prior to intubation. And these are quartiles by blood pressure. Now, what you see is that The top quartile, which is the people with the highest blood pressure prior to intubation, had the biggest drop in blood pressure. They had a systolic blood pressures of 148 or above, so they were bang in the normal range, and they had the biggest drop. And we saw that also with fluid bolus. We didn't see any effect of fluid bolus or of vasopressors. And we also looked at propofol use. Here there seemed to be a suggestion that the fourth quartile, the people with the highest blood pressure, if they had propofol as part of their sedation, they had a bigger drop in their blood pressure. So when we looked at that in a multivariate analysis, what we saw was that propofol was independently associated with the risk of hemodynamic instability. And that's a potentially modifiable element of our practice. And I would suggest that's probably something that comes from us really wanting the best possible intubating conditions in these patients. So we are now looking, this again is a study led by Vincenzo Rosotto, and we're participating here in Ireland and also France and Italy. And we're looking at pre-intubation noradrenaline use in these patients. So we're stratifying use based on pre-intubation blood pressure, randomizing them to either noradrenaline or standard care, and looking at the incidence of cardiovascular instability. So that study is underway. We've targeted 800 patients. We're at about 250. So to kind of wrap up, the physiologically difficult airway, I think, is something we are starting to understand a lot more. We have to change some of our paradigms and our thinking in terms of how we think about the anatomically difficult airway and how we practice in the OR versus how we practice in the ICU. We have to acknowledge that this is a much more uncontrolled environment, right? So the situation is, these skills vary, operators vary. You rarely have, multiple backup like you'll have in the operating theatre. And while preparation is vital, it's actually very, very hard to prepare for these cases. So you have to anticipate, you have to plan your solutions. There is a guideline document being developed where there's a requirement for at least one skilled airway expert to be present. And in terms of steps to reduce hypoxemia, you need to think about the apneic period. And so high flow appears to be a good option there. Non-invasive ventilation would be difficult to implement, but it does seem to have a role. And that, in terms of first pass intubation success, it's important, but it's not the only thing we should be looking at. We need to really focus on reducing the risk of cardiovascular instability and collapse. Fluid loading does not work in these patients. I showed you one trial, but there's actually been a number of them. We should be really thinking about avoiding propofol. And we're looking, as I said, in the French study at pressor therapy. This is a recent expert guidance that was published that I was fortunate to be part of. They're sort of starting to try and set out the parameters in this areas of study for trying to improve the care of these patients. And with that, I'll finish. I'd like to thank the participants in our trial and in our study and in the other studies. And again, to reiterate my gratitude for being the Siobhan Mythen Lecturer this year. Thank you.
John, thank you very much indeed. Really fantastic scholarly lecture. I loved it. And actually some of it's going to change my practice. So thank you.
TopMedTalk.
TopMedTalk is the broadcasting arm of EBPOM, Evidence Based Perioperative Medicine. Join clinicians from around the world at EBPOM World Congress 2026 between the 7th and the 9th of July at the British Library in London. 3 days of evidence-based perioperative medicine, global insights and expert debate, featuring speakers including Michael Marmot and Ken Rockwood. Go now to edpom.org. That's edpom.org.